Um, Welcome to everybody. It's nice to meet you again. So really, I thought I put a few slides together, but I didn't know if anybody sort of wanted to have a bit of a discussion after or ask questions. Let me just see if I can get my slides up.
While you're doing that, Charlotte, can we all put ourselves on mute so that we don't get any feedback? That'd be great.
Sorry. That's it. Can everybody see my screen? Yeah, brilliant. Okay. So, so as Bob said, I'm Charlotte Bloodworth, which is a terrible name. Definitely didn't choose to be in this area of healthcare. Just happened to come into it, but definitely got a very memorable name, if nothing else. Bob's just invited me today to talk about clinical nurse specialists. I am an advanced nurse practitioner, which is slightly different. So I'll tell you about that as well, because I mean, you might have people with different titles in your own hospitals, and hopefully I'll be able to give you just a bit of clarity about the difference between us. But I'd say even though we probably all are specialist nurses, and me especially, I started off in haematology in 2003 and rotated around all the sort of departments and became a specialist nurse in about 2009, I think it was. So I've been a specialist nurse for quite a while now, and I've developed my role into this advanced nurse practitioner, which I'll tell you about. But really, it's really sort of to tell you what a specialist nurse is and why we're very important, and hopefully give you a little bit of insight into the role and sort of the driving forces for the role. So hopefully that's what you wanted. So I'll start off right at the start, really. So the reason everybody should have a specialist nurse is because of the government strategy. So the cancer plan, basically, there's one for NHS England, and then sort of all the devolved regions develop their own as well. So I've just put up the Welsh one here, the quality statement for cancer, but they're pretty much along the same lines. Within the cancer plan, you'll have an area that's person-centered care. And this is where it basically says that anybody that's been diagnosed with a cancer should have a key worker. So that's somebody who the patient, with the patient's agreement, takes a key role in coordinating care, promoting that continuity, making sure people know where to access information from. And anybody that's been diagnosed with any cancer should have an allocated key worker. I've also put up a picture here of, in Wales, we've got the cancer pathway, and this key worker is sort of key in this pathway as well. So there are certain points within the cancer pathway where you have to meet your key worker, and your key worker has certain things that they have to achieve within the sort of diagnostic pathway. So patient experience, I'll just move this picture out, is one of the central pillars of care, and it has been associated with safety, improving safety, care effectiveness, and improving health outcomes. And it's actually also been proven that having a specialist nurse can actually help survival in patients with cancer. This is a very recent piece of work that's come out off the back of the National Cancer Patient Experience Survey. And they basically found that those that had a specialist nurse actually had a better survival. So the definition of a clinical nurse specialist is a registered nurse who provides this key working that's in the cancer plan for a group of patients. From the point of contact, they plan the patient journey, assess and signpost to certain services, and every patient should have a key worker as per the cancer plan. Within that, they have responsibility for doing holistic needs assessments, end of treatment summaries. And from our point of view, we consider this role as very patient focused. So we consider them really the face of the team, even though everybody sort of thinks as the consultants and the doctors as heading the team, accessing them is often quite difficult. So the face of the team, or the person on the door, is usually the specialist nurse, and that's the way that you can sort of get in and get the communication through to consultants if you want to do it that way. But what they're very much not is a personal assistant or a secretary for the team. It takes a while often when we get new doctors to sort of get them to understand that bit, because they see that communication. It's sort of, there's a fine line between being a PA and being this communication for the team. So I put a slide up here. I've put up, the next two slides are really quite busy. These are from our practice, really. They're the sort of points on the pathway that your specialist nurse is responsible for, and sort of the jobs within that pathway. So as the cancer plan said, from the point of diagnosis, you should have a specialist nurse. That specialist nurse will be there, hopefully, while you're getting your diagnosis, but if not, they'll follow it up after. And really, they're there to help you understand a lot of what was said. Sometimes that means sort of translating some of that medical jargon into a way that's more understandable, or if you don't need to translate, just going over some of it, because a lot of the time I think we absolutely bombard you with information, and it's a very stressful time, and in a way only part of it is probably retained. So we're there to sort of go over it again, give you some written information. At the same time, we've got a job to do, which is assessing the sort of holistic needs. So that's a little bit more, not just looking at your disease, it's how you're going to cope with things, how you're going to cope with treatments, what support you've got. And these are the things as nurses that we're really looking at. The doctors are focused on what your disease is doing to your body, what treatment's going to be best for it, whereas we're thinking about how are you going to cope with certain treatments? Have you got the support there? Are there things that are going to help you throughout the journey? So that's on diagnosis. So it's very different whether you go straight onto treatment or whether you go into that sort of surveillance phase. The needs are very different. So again, your specialist nurse, if you go into the surveillance, the watch and wait phase, the specialist nurse remains your key contact. So hopefully, if you have a question or, need some information, you've got someone direct that you can contact. Throughout that time, there'll be ongoing sort of assessment of your holistic needs. There are lots of new support things that come on. So it's sort of our job to make sure that you know what's out there and to signpost you to things that, may be of benefit, because there is a lot of information out there, and sort of selecting things that will be most helpful is part of that assessment. And we're very much still the main communicator within that sort of team, between the doctors, between the pharmacists, and other allied health professionals. So the surveillance bit is probably the bit, I would say, that gets ignored, or not ignored, or less acknowledged, because you only see people sort of, once every 3 months, 6 months. And sometimes you might not even see them. They might come into clinic and go before you even get a chance to, catch up with people. But the important thing is really making sure that if you do need to speak to the specialist nurse, or you want to, that really it's still part of our everyday job to be there. If you go straight into treatment, this is the bit where you'll probably see us a lot more, because we're the ones that coordinate the pathway. We're there booking the treatments. If you need any sort of fertility preservations, we're the ones that will then send all the sort of referrals off for that, vascular access. So if you don't have very good veins and you might need certain treatments, we're again responsible for that, getting all those referrals in, getting the veins assessed, and again referrals for things like plasma exchange or transplant, again very much sits with the specialist nurse. So again, we'll remain the key contact, and we've got that ongoing sort of holistic assessment and signposting. And again, very important, we're the main communication within the team, between all the team members, between you and the team members. And I'd say over time, hopefully, we get to know you quite well and we get to understand what's important to you. So in a way, we're often your voice within some of these sort of multidisciplinary meetings. We're the ones that sort of, I mean, I suppose I'd say sort of ground conversations, you know, take it away from something that's a little bit abstract, just treatment disease. We're the ones that bring it back to real life and bring a bit of sort of, you know, the human side of things into conversations. So, and there's also, of course, the end of life support as well, which again is a really important part, and that's our day-to-day job. So that's sort of a quick overview, and I'm going to put up another slide now, which is extremely busy. I don't expect you to look at it in detail, but this is specifically Cardiff. So this is specifically the planning for our support. So I put in a few numbers here, so you can see the sort of numbers of people that we actually come across. So in our team, we've got me and we've got two specialist nurses. So the specialist nurses are the ones that are key workers, and my role's a little bit different. It's a little bit removed from that. So our two specialist nurses, who are actually part-time, are responsible for key working about up to 2,000 patients a year. So we get about 300 people as a new diagnosis a year. So this is just Cardiff, which is probably definitely not one of the biggest centres, but it's one of the biggest ones in Wales. We meet these new patients, these new diagnoses, mostly in outpatients. We have two hospitals that we cover. So they might be at the Heath Hospital or they might be at Llandoch Hospital. We have to cover clinics over both sites. And of course, we've got the ward site as well, which again, we've got two wards since COVID. We have a sort of separated admissions unit before you can get onto the proper ward. So again, we have to make sure that we sort of capture all those diagnosed new diagnoses in the year. So that's our sort of prehab stage. And if I can just move these pictures. So I've written some details about what we actually do in that prehab sort of phase. We do all the workup that I told you about, you know, whether we need to book treatments, we need to book fertility, preservation, order PICC lines, refer to social support, and follow up all those people that we don't actually get to see for the first time. Quite a few people will come in quite sick, end up on the ward, and we sort of have to sort of chase our tails with people like that, because they'll meet all the ward nurses, but they sometimes don't get to meet the specialist nurse straight away. So that's one part. And then we have, out of that 300, probably about 175 people will go on to active treatment. So again, that's across 2 sites. It might be at the main Heath Hospital, or it might be Llandoch Hospital, or it might be the ward. We've also got an ambulatory care unit. So again, we're sort of looking after people on treatment across sort of a wide area. We've also got people that we've got on telephone contacts and in outpatients on oral treatments as well. So it's quite a few sort of people to keep an eye on in different areas. So we've got about 250 people with lymphomas that are curable and dischargeable after about 2 years. So we've got people, we're basically responsible for that sort of end of treatment follow-up and then the discharge phase. So once people finish treatment, if they've got a curative lymphoma, they'll get their end of treatment scans. They'll then go through to the nurse clinic and have that nurse follow-up and then get discharged from the nursing team. So we've got about 250 people that we see a year in that sort of discharge clinic. We also run a telephone clinic, again, across both sites, and that's for people with low-grade lymphomas, CLLs, that are on sort of a virtual follow-up rather than the ones coming to clinics. And that sort of crosses over to the outpatient side, where we've got people on surveillance, and that's sort of the brunt of the work, if you know what I mean. That's really where our main quantity of patients sit. So again, I don't want to go into too much detail because it's probably very boring for you. But just on the right, I've written a list of things that we do sort of at each stage. So the prehab stage I told you about, mid-treatment, we've got a shared care list. So we're a tertiary centre. So we have people referred from different parts of Wales for certain treatments. And then they go back to their local centre in between times. So we have to sort of keep that communication going. We also are part of the MDTs, part of the ward rounds. And we have sort of a CNS, a virtual clinic, where we'll put patients in to phone up if we've got sort of complicated things to follow up. We've also, at the moment, we constantly have new projects, and at the moment our new project is to be start being very proactive with advanced care planning. So we've got a big project coming up about that, where we're going to start sort of advertising and inviting people in to discuss advanced care planning if they want to, because that's something that we found that we're quite poor on. And we also ideally we'd like a monthly sort of support group for our outpatients or people having treatment, to let them know about all the services that are out there. But at the moment we're sort of running them as a course, and we've done 2 of those courses, but we aim to do more. And then we've got the rehabilitation side of things. So that discharge clinic, we have end of treatment summaries, refer on to end of treatment courses, and I've also written there doing a lot of disease assessment and clinical examination skills. So it's actually the point of that slide really is just to show what a specialist nurse does day to day, and it's actually quite a lot that we have to fit into our days, and it's a lot of patients that we cover. I think when you come into being a specialist nurse, you're perhaps a little bit naive in thinking, I think it was Macmillan that put those adverts on saying that, you know, your specialist nurse will be able to hold your hand through the whole of treatment, and be there for you at any time, you know, which would be absolutely fantastic if we could, but we definitely can't do that in the quantities of numbers that we're talking about. So this is the bit where, you know, I mean, in the cancer plan, it says, everyone should have a key worker, which might be your clinical nurse specialist. The titles can sometimes be quite confusing. Not everywhere uses the same titles for the same roles. A lot of people now are having cancer navigators, which are doing, part of the work that clinical nurse specialists used to do. And I think when we went to the WMUK patient day, there was a doctor there from Scotland, because I think Scotland's the only area in the UK that doesn't stipulate that you have to have a clinical nurse specialist. But the doctor there was sort of saying, although they're not called clinical nurse specialists, you'll have people that do a similar role, and I think they were called navigators. So the clinical nurse specialist really is the key worker. They're your advocate, they're there for communication and support. And then really, the more skilled that nurse becomes, you get put on clinical examination courses, prescribing courses, and the more experience you get, the more autonomous you can be, the more decisions you find yourself making. And also advanced nurse practitioners, to be called an advanced nurse practitioner, you have to have a university accredited course that goes with that, and part of that is a competency portfolio. It's a master's level course, and that gives you that sort of increased governance. So I went through that route. I found that I'd been a clinical nurse specialist for a good decade or so, and really I was finding that I could definitely do more and give more to the service, and the service needed expanding. So I sort of expanded my role in response to sort of help the service. So I can do that clinical examination, I can prescribe, I can do some autonomous decision making within a scope of practice. When it goes out of my scope of practice, I'll then escalate to one of the doctors or the consultants. But there's quite a lot I can do now as an advanced nurse practitioner that sort of blurs with my previous role as a clinical nurse specialist. I had all that sort of very nursing, holistic side of things, but I could also do your examination and I could prescribe your next medication, as long as things were going to plan. Part of that includes being able to dose adjust according to side effects and toxicities. But once they sort of go out of that sort of very defined scope, that's when you escalate and you get some medical help in for those complicated things. And that, I would say, for our service, freed up our doctors quite a lot to be able to concentrate on those sort of new diagnoses and concentrate on those really complicated medical things, while I could do the day-to-day work. But also very much, I'm not taking over from the doctor. I've added a few roles of the doctor into my role. So I very much come from that nursing background, and my priority is you, and are you coping with the treatment? And if you're not, that's very important for me to then go and tell the doctors, we need to do something, this isn't working. So sometimes somebody might come for their routine clinic review, but they'll see me. And then they might come 3 months later, they might actually see one of our doctors, might come 3 months later, and they might actually see our pharmacist, because our pharmacist also has an advanced clinician role. And she can also examine and prescribe and do that consultation. So we quite like it in Cardiff, because I feel that really we're giving a better service than a lot of places that have only got a medical team, because we've got our pharmacist who's very directed towards your other medications, whether you should be on these other medications, as well as doing that sort of general clinical examination and prescribing your next medications. You could then come and see me and you get that holistic side of things. you know, what support do you need? Should I be signposting you anywhere? And then you get to see our doctors on another occasion who will be very focused into sort of the medical side of things. So in a way, you get a richer consultation than other areas offer. So I've just put in a few slides about support services. So I would say each hospital is really different as to what they offer locally. So it's very important really to find out what your hospital offers, and really your specialist nurse is the person that will know the most. There's another layer under that, which is sort of specific to support service, specifically to hematology. So, you know, that's like WMUK. So it's a national charity there to offer support. You know, the Lymphoma Action, Bloodwise, you know, all the sort of specific hematology services there. And then you've got another layer underneath, which are all the sort of cancer support services. So Macmillan, Maggie's, that type of thing. And then there's another layer under that, which is absolutely enormous, which are the wider sort of support networks like Mind and you know, lots and lots of things. So there's actually a lot of support out there, but it's sort of, I'd say your specialist nurse will be the one to signpost you to ones that perhaps would be more helpful to you. You know, you might know what's more helpful to you, but you might not know what's more helpful. And I'd say from experience, we often would encourage certain services or encourage you to engage with certain services just because we know they're really helpful or they've been helpful to other people. So I think there's so much out there, but knowing what was good for you is the bit where your specialist nurse comes in and you know, has a discussion and suggests things. If you live in Wales, just a quick plug for our video. So all the CNSs in South Wales, well, actually North Wales as well, did contribute to this. We got together and discussed, I'd say between us in that picture, the four of us nurses have over 80 years experience as specialist nurses. So we just got together and we were discussing the services really that we found the most helpful over the years. And we've just sort of presented them in a very short YouTube video. So everybody in Wales hopefully will get given one of these little flyers to have a look at the video to see what support services are out there. But this is the type of things that your specialist nurses are doing. You know, this is just us in Wales. Your nurses will be doing something different in their own areas. I think everybody does strive to improve their services and do all this sort of projects to improve things. And then my last slide here is really just to show you that Macmillan quite recently issued a report about cancer nursing and basically said that the pandemic has exacerbated the strain that we've got on the cancer workforce, which was already quite short-staffed before all of this. A lot of patients now are experiencing longer waits, cancellations of things, changes to appointments, and some people are getting a later diagnosis. I'd say we've been very lucky in Wales that we weren't redeployed. We were all able to carry on with our treatments, but that didn't happen across the nation, and a lot of nurses were moved to help on the sort of front line, and that's now caused a big backlog. And another thing that sort of exacerbating all of this is the fact that a lot of specialist nurses are older because they're more experienced and they're coming nearer to retirement. So you know, the workforce really is under strain at the moment, and I think this is part of the reason why nurses are going on strike, really just to I don't know, bring to attention the fact that you know, a specialist nurse, from my point of view, is so good and so helpful. But the sort of expectations on you are more and more and more. And I think, you know, we need to let people know that it gets to a point where, you know, we want to offer all these things and we can't. So that's part of why we're on the strike. And that's it. If anybody.
Okay, Charlotte, that's brilliant. Thank you. So I'm gonna if it's okay with you, Charlotte, we've got about 25 minutes to do some questions, if that's okay. What I would ask you to do, guys, if you I've told you this before, I'm sure most of you know this, on the bottom of your screen is reactions. You press on that and the bottom panel says raise hand. And when you raise hand, a little hand comes up that I can see, and Stephen and Dave have already done it, which is great. I'm going to lower mine. Just two quick things. On your second slide there, Charlotte, which was the official cancer plan, I noted that it says the word must have a key worker. It wasn't should, it was must, which is what I try and tell people whenever I speak to them, that you must have a key worker. That's for England, Wales, and I guess Northern Ireland, but I don't think it's Scotland. And the other thing was that your very busy Cardiff slide, of course, talks about all lymphomas and not just WM. You haven't got 300 WM patients a year coming in through Cardiff. I hope not. Anyway, so let's start with the questions then. So Dave, you're first up. You're on mute, Dave.
Yeah, just unmuting.
There you go.
I'm a bit steady. Yeah, the allocation of the key worker, should that be by name or just a telephone number or what?
So yeah, I'd say the cancer plan says a named key worker. So you should have a name for your key worker, but I would say it's not necessarily the same person throughout the whole journey. When the idea came up, it was really about changing your key worker for certain points along the journey. And ideally, sort of GP nurses were supposed to be part of this cancer key worker name. And initially, it sort of came out with a card that you could sort of pull out like this, and it would start with one key worker and then change regularly. But I think the primary care wasn't as keen to be involved in the key worker strategy. So I think overall it's been adopted that the clinical nurse specialist has become that key worker.
Right, well, I've not actually been given a key worker, but I found my own. I'm under Leeds, and so I got the telephone number of the Leeds CNS, and I rang them at that time because I had a specific question. But now I've got another problem, and so they never contact me. I'll be contacting them by email, and it'll be, I think there's 3 of them at Leeds, so it'll be one of the 3 that may reply to me. But I only seem to be really only half onto their books, because I live in Lincolnshire, and so I only get telephone appointments with my haematologist. So I'm only sort of half on and half off the scheme, really.
Yeah, and I think that very much depends on how each area runs their service, because in some areas the specialist nurses will do the telephone appointments, and then you get to know your specialist nurse a lot more, you know, if you're having that contact. Yeah, I'd say if there are 3 nurses, they often will specialize in certain areas. So again, they probably just haven't made it clear who specifically you're under. And they're probably sort of offering cross cover as well. It's very difficult to speak for the whole of the nation.
No, of course.
Yeah, I can definitely speak, I'd say, from my point of view, because I've been in my role so long. initially I was the single CNS for both lymphoma and myeloma, you know, so the numbers were absolutely enormous, and I couldn't cover every single clinic. And I'd say for at least the first sort of 4 years, I probably never met anybody that was on surveillance, just because I never was able to cover that surveillance clinic. So a lot of the time, even though I was their named key worker, if you sort of looked on the cancer registry, you know, people have to have a key worker registered, and my name was probably registered for hundreds of people that I never ever met, but would have been there had somebody contacted me for something.
Right. The question I want to pose to my CNS is to get some assistance with a specific blood test, which is the PV. It's slightly complicated with me going to Leeds. So the hematologist talks to me on the telephone. He sends me a request, goes to my GP for the bloods, and I take the blood sheets to the local hospital. The local hospital cannot do PV, so they send it away. They've done this 3 times, and each time, twice it's gone to Sheffield, and once it's gone to London. On all 3 occasions, they've failed to be able to make a measurement. So all 3 of these over the last 6 to 9 months have failed, and I've not got a PV reading. Is it something the CNS could assist to speak to the pathology department to endeavour to get the PV testing?
So I would say yes. So I would say, do you mean like plasma viscosity? Is that PV?
Yes.
So I would say, again, in Cardiff, we don't measure plasma viscosity. On the odd occasion where we do want it, we probably had to have the clinical nurse specialist involvement to make sure that it was taken and sent to the correct place. So I would say, if you were phoning me, asking me for assistance, I would think that's definitely something I would help with. So
right.
I'd say get in contact with them. I think they would help you.
Yes, thank you.
Thanks, Dave. Just on that note, certainly I know from Addenbrooke's Hospital, we've got 3 CNSs. I think they all work part-time. So you might not get an allocated name, but you certainly will get an allocated phone number, depending on which day of the week you rang up. So I'm sure that happens in a lot of hospitals. So Steve, you're up next. Steve McGraw.
Charlotte, that was a great presentation. Thank you. One thing that really struck me in your presentation was how proactive you are in Cardiff. And if I compare that to my situation, I was diagnosed 12 months ago, went straight into treatment. I finished treatment about 6 months ago. I have the key workers. They're very helpful, but it's purely reactive. So if I phone them, it's normally an answering machine. They're normally very good and they call back within the hour. So no complaints there, but it's only a reactive relationship if I am requesting something. I've never seen any proactivity. Are you unusual, or should I be expecting more at my local hospital?
So again, I think every area is different and everywhere's got different demands on them. I'd say it's often very driven by the people that are in the team. And I don't mean just nurses, whether you're enthusiastic nurses, it's whether the whole team come together and whether you do a lot of service improvement. I'd say we're definitely, the slide I put up was our plan. So it doesn't always go to plan, but we're always trying constantly to improve the service and get feedback every year about sort of things that we do change. So I definitely don't think we're unique. I definitely go on sort of study days with other specialist nurses in lymphoma that do similar things and share similar sort of pockets of good practice that you then take back to your own place. So I would say I'd be surprised if every area is not doing something, but whether or not it's making an impact might be different.
Okay, super, thank you. And just one very quick point to make, because I know it's come up before about people not knowing who their key worker or CNS is. One of the good points of practice I see in my local hospital is every time I receive any letter from the hematology department, just a standard letter confirming an appointment or anything, it actually always details the key workers' names and the phone numbers on there. And I think if there's any hospitals not doing that, you know, perhaps we should ask them, because it's a really good reminder to know who those people are and what their direct telephone number is too.
Thank you, Steve. Penny, you've been putting your hand up. Take yourself off mute.
Thank you very much. Yeah, that was a really useful talk. Thank you, Charlotte. Simple question, how do I get to find out if I have a clinical nurse specialist?
Have you been given any contact numbers at all?
Well, I can phone, I'm with Withybush Hospital under the wonderful care of the consultants, but also Tracy. Well, yeah, I saw her in something presentation you put on earlier. She's great, absolutely wonderful. But I don't know if she's my clinical nurse specialist or if she's a key worker, but I've got the phone number of the ward, and they are really, really responsive. I'm very lucky, but I'd just like to know, do I have a clinical nurse specialist? Is that likely to be at my local hospital, or is it likely to be in Cardiff? I live in West Wales, West Wales.
I would say Tracy is your key worker.
Okay.
You know, I think it's, some places will have like a card saying, you know, your key worker is Tracy. Tracy is a specialist nurse in Withybush. So I presume she would be your key worker. It's probably just never been said in that way to you.
Yeah, that's quite possible. And is there a huge distinction between a key worker and a clinical nurse specialist? I mean, or is it completely blurred between those two roles?
So I'd say it is blurred. It was blurred since the cancer plan first mentioned it, and I think in a way it's quite a confusing term, because it's a new term. You know, they should have just said everyone will have a clinical nurse specialist, because you know, your clinical nurse specialist doesn't have to be your key worker. You could have a key worker that worked in the GP practice. It's just over time, over the years, it's ended up being the clinical nurse specialist, because they're in that role of that sort of communication and main support. The thing about Withybush is that it is a district general hospital. So Tracy is the CNS down there, but she's not only doing lymphoma, she'll do myeloma, leukemias as well. So she covers everything, because she is the only clinical nurse specialist there. I think there's actually a new one that's just come into post. So yeah, so it's about how we sort of present ourselves as key workers and specialist nurses. You probably communicate with her the most, but she's probably never sat down and said, right, Penny, I'm your clinical nurse specialist.
That's true.
Yeah. So we have it written, we have sort of a key worker booklet that we gave people, again, trying to be proactive to try and explain what we are and who we are. And we've got sort of our pictures in it to help people know who to contact. It is very confusing, and it is different areas.
And it's also the fact that I was diagnosed a very long time ago, and I've been on sort of fairly low key observation and recently. So, you know, over the years, you forget what leaflet you were given. So it's just nice to know that, that Tracy, as you say, is my key work / clinical nurse specialist, and I don't need to go and look for any further, really, for the time being.
Thank you, Penny. And
Thank
Keith,
you.
you're next up.
Hi, Charlotte. I'm at Wrexham Mailer Hospital. I don't have a WM specialist in Wrexham, but I've got a very good Dr. Watson, who's an haematologist who I see. I've got 2 clinical nurses in Wrexham, which have been very helpful. They give me a card when I first went in with both the contact numbers, and they've been great. When I needed a shingles vaccine, they got in touch with my GP and told them that I had to have Shingrix in Wales, where my GP wouldn't give it to me. And they sorted that out. And they also got involved when I had COVID and put me through to get antiviral. But I haven't seen one of these leaflets that you showed today. That's very interesting, with telling you different people are in Wales. Would I be able to get that through the...
Yeah. Did you mean that the bit I put up at the end with all the
Yeah, the little leaflet, yes.
yeah, so we did no one from North Wales could come and do the actual filming with us, but they were involved in giving us information about services that were available in North Wales. So they also have a stack of those leaflets. So I'd say speak to either of your clinical nurse specialists. They'll definitely be able to poster out one of those leaflets. Yeah.
Yeah, because when I was diagnosed with WM, I think my samples come to Cardiff. That's where they confirmed it. Yeah, but
yeah.
I know there are other WM patients at Wrexham, but I don't know them. But I know they tell me they do see others. Okay, thank you.
Thanks for that, Keith. And Gordon, you're next. You're on mute, Gordon.
That's it. Right, thank you very much for that. That was very interesting. I did see my key worker initially just after diagnosis and just after 2 sessions of plasma exchange. Jackie Stones, she came to see me, gave me a little booklet prepared for me for chemo, and a little card with her name on, and also the office number of the clinical nurse specialists, and also a yellow neutropenia card, warning her that I must be put on the neutropenic pathway if I get into trouble. And I do have 3 clinical nurse specialists that I speak to regularly. They call me 6 weekly, consultant calls me 3 monthly, and if I need anything in between, I can always contact one of the clinical nurse specialists, and they are brilliant. Tina, Jazz, and Jess, and they are absolutely brilliant. And I think they do a marvelous job.
That's great to hear, Gordon. Thanks for that.
I think I'd like to say the final statement from Charlotte, I wholeheartedly agree with. And just to wish everybody in the NHS more power to their elbow, and I hope the strike works. And
yeah, I think we all agree with that, Gordon. Thank you. Thank you. I can't see any other hands raised. Does anybody want to wave at me if they've got a question? Nikki, I'm assuming you nor Peter don't want to ask questions. Anybody else? Great. Well, this has been recorded, as you all know. We'll try and post. I'll get Louisa to try and post it by Monday, so you can watch it again. I recommend you watch, even if you're not in Wales. It's worth seeing that video, that YouTube video that Charlotte. I've seen that. I saw it when it was made about, I don't know, 6 months ago. It's a really good video. Really good video. It's worth looking at if you're in Wales. And I just want to say a big thank you, Charlotte. You guys will be pleased to know that Charlotte, I hope, has accepted our invitation to join a nurse advisory panel that we're trying to set up with 5 or 6 nurses from around the country, including Scotland. And Charlotte has very kindly agreed to be part of that. So that's where we're going to really start getting our nurse training days in order and getting the word out to all of the clinical nurse specialists about WM and about WMUK, and hopefully take the burden off of some of the nurses if we at WMUK can answer some of the questions. So I look forward to working in the future with you, Charlotte, and meeting up with you again. Thank you so much for joining us tonight. We really appreciate you giving us your time, and thank you all for joining us tonight. Okay.